Morning, everybody. I'm Teresa Cope, and I'm the Chief Executive for Manx Care. And I'm joined by some of my team here who will join me on stage for the Q&A afterwards. What I want to try and do this morning is just give you some insights into some of our new developments and our transformation plans moving forward. If you were at the conference last night, you will have heard some really clear messages around the funding position in health and care and what that is meaning in terms of impact for patients, service users and their families. And I guess I don't want to argue with that. The model of healthcare delivery that we have for the island is both unaffordable against the budget we have and unsustainable in terms of delivery. And what you'll hear today is some proposals which sort of accelerate the pace of improvement, because not only will they ultimately mean greater value for money for the island, but they will accelerate to where we should be and potentially gain sort of 20 years of progress in those areas of health and care delivery. So the future models of healthcare that I want to talk about is around urgent and emergency care. So those people that need urgent and emergency care, and those people that need what we call intermediate care. So that's that care delivery between hospital provision and primary care, allowing people to remain independent in their own homes and in their own communities. And intermediate care has never really existed in a comprehensive way on the island. And neither have we had a comprehensive urgent and emergency care system. And I'll show a bit more detail about that. We have a great opportunity here on the island to deliver health and care in an integrated way, making sure we provide seamless care whenever possible, that we join up our service provision, we make it as efficient as we can, and ultimately achieve good outcomes for our patients. So this is the team that you will see on stage shortly. Will Bellamy, who's at the front, who's our head of ambulance service. David Hamilton, who heads up our social care, safeguarding and mental health services. Anne-Marie Cubban, who's our primary care lead. Oliver Radford, who's our executive director in charge of all of health services. And Michelle Breed, who has led the intermediate care project, who's a therapist and is leading the implementation of intermediate care. So we have a vision to be the best small island health and care system in the world. I wouldn't have taken this job and be stood here talking to you today if I didn't believe that was entirely possible for the Isle of Man. We set 4 strategic priorities when Manx Care was established. We needed to improve the quality of patient care and the safety of patient care. And as we touched upon last night, a lot of that has been hidden and in the background, but I cannot underestimate the amount of work that has been done to make sure that the standard of care that we provide is a good standard of care. Last year, we were regulated by the CQC and inspected for the first time, and Ofsted in our children's and family services. With regulation comes the need to act, and we had to prepare extensively for those inspections. As the island's health and care provider, we must provide the assurance to the public that we are providing safe care, quality care. And inviting the Care Quality Commission and Ofsted to inspect our services means we have a new bar, and we must make sure we meet that bar and are able to provide assurances on that. We've also wanted to focus on a positive working culture. We want Manx Care to be a great place to work. We want to be able to offer great training opportunities to our staff, to retain our staff. So a positive working culture is about, having career aspirations, a meaningful programme of work to do, but also it helps us recruit and retain in a hugely competitive market for health and care professionals. We must improve our financial health. We have always overspent in health and care, and as we talked about last night, the demand for health and care will always outstrip the resourcing that is available. There is no amount of money you could keep pouring in. What we have to try and do in health and care is prioritise and also ensure we've got value for money for the services that we do have. But we are on that precipice of having to make really difficult choices and difficult decisions about what we can afford to do and what we can't. Part of what we'll talk about today are some of those schemes which ultimately bring us up to date, but also in time will deliver value for money from this system. We also want to promote integration. We have to work collaboratively with the North West for some of our healthcare provision, and our third sector partners are hugely important to that overall pathway and delivery of care. We are a system, and those partnerships are equally important. At the moment, we provide too many services within a hospital-based setting, both in terms of Nobles and Ramsey District Cottage Hospital. Hospitals are valuable commodities. They cost a lot to run, and indeed the demand in healthcare means that we will have to keep building extensions and extensions on those buildings unless we change the model of delivery. We need to try and protect that hospital capacity and future-proof. We are already building locked. We do not have any spare space to put additional wards, and we have an emergency department which was built to cope with around 20,000 attendances per year. It's seeing double that. So we have to really make that shift and move services from hospital-based delivery into community where it's appropriate to do so. In most cases, moving that work out of hospital also improves the outcomes and the experience for individuals. So this is what we're aiming to achieve. Our hospital won't shrink, we won't make it smaller, but what we will see is a growth in community-based provision. So, the principles apply that we are going to focus on treating people in the right place at the right time in an integrated health and care system. As I say, we cannot afford to continue delivering services in the way we currently do. So, those new models of care are around see and treat, hear and treat, intermediate care, ambulatory assessment and treatment, and primary care at scale. So, why are we doing this? Well, as I said, if you just took the ambulance service as an example, the operating model we have for the Isle of Man ambulance service is the same as it was in 1994, 29 years ago, the year after I qualified as a radiographer. We have allowed our services to drift and not be operating on a contemporary model. In the UK, 50% of people who contact emergency services are not conveyed to hospital. Our percentage is much, much higher, 90%. It costs, and I don't want to make this all about money because this is about making value for money for the system, but an emergency department attendance is around £400. A bed day is around £580. So just to come to hospital, have an ED appointment, stay in hospital one night is around £1,000. And so many patients don't need to have that journey. So, hear and treat. So this is around qualified, trained practitioners, usually paramedics, working as clinical navigators in the emergency services control room in order to provide advice, manage demand better, triage better, prioritise patients, identify different pathways that people could be disposed onto, and ultimately, this is about getting the right care in the right place at the right time. We've already started this. We piloted this over winter, and we will have full 24/7 delivery from mid-2024. This is a real change for the public to understand. So no longer will you dial 999, speak to a non-clinician, and an ambulance would automatically be dispatched and take you to hospital. That will no longer be the pathway. You will dial 999. There will be someone speaking to you who is a clinician, who can advise you, who can make a judgment and triage you, and ultimately you may not be conveyed to hospital. You may have care delivered at home or be advised to seek care elsewhere. See and treat takes this one step further. Okay, so when the ambulance is called, our clinical assessment, our paramedics would be dispatched to someone's home. They are skilled, they are overseen and supervised by a consultant paramedic. They can immediately assess, diagnose, potentially treat, and just make sure that someone is safe to be left at home and not conveyed to hospital. This enables people to stay in their own home, have a care package close to home, and will save some ED attendances for us. All properly clinically assessed, and this will be in place from early next year. Ambulatory assessment and treatment. Again, the 4-hour target, which was used universally, almost drove a propensity to make a decision quite quickly and admit people into a hospital bed, when sometimes a longer assessment period, some diagnostic testing, would help confirm a decision and potentially prevent an admission to hospital. So our ambulatory assessment and treatment unit means we have a little bit longer in a dedicated space to assess people, diagnose people, provide treatment if necessary, and that will also avoid a hospital admission. Again, this will be coming into effect from early 2024. Intermediate care is such a fundamental and important building block, particularly for the elderly. It bridges that gap between hospital-based care and primary care. Hospitals are great. We all need them at some time. But when you are frail and elderly, the level of deterioration that can occur in hospital can be harmful. We've got to balance that, delivering care against potential harm. And intermediate care is all about re-abling and enabling people to remain independent, remain in their own homes, providing that level of support. And it has been a fundamental missing tier from this health and care system. It allows the primary care practitioners to step people up and allows the hospital to step people down quicker and give them the skills to remain independent. Again, all focused around trying to protect that hospital-based capacity and only use it for the patients that really, really need it. It's not a detrimental standard in care. It's not a compromised level of care. It's an appropriate and alternative pathway, evidence-based and better value for money, and usually much, much better outcomes for patients. And that's the important thing. It is value for money, but it's also better for patients. Primary care at scale. Primary care and what happens in the community around health and care provision is the absolute bedrock of good health. And I would include public health in that too. We need people who are able to access care locally and be able to keep themselves well. So there's a theme here around keeping well, remaining independent, remaining in your local communities. Primary care at scale is focused here on the island around our primary care homes in the north, south, east and west, combining our wellbeing hubs with local practices in that model. Now, we have a strategy for primary care at scale. The Manx Care Board signed it off earlier this year, but it requires a significant amount of investment. It will yield the benefits over a 5-year period. But at this moment in time, it's unaffordable, and primary care does need some level of stabilisation before we move to that. But this is all about building capacity in primary care, looking at additional practitioners who are part of the primary care team, looking at virtual solutions as well as face-to-face solutions, looking at different models of recruiting and retaining GPs and other primary care professionals. Not everyone, not every practice wants their own contract. The salaried model is a viable alternative. We need to take all of the learning from the CQC reports and also look really objectively at the work which should be done in primary care, and that also needs to move out of hospitals. So this is the current model, a very fixed and inflexible model where your GP is the first point of contact, and there are lots of referrals into secondary care services, mental health, community nursing, diagnostics, social care, hospital-based care. That no longer works really well, and we've got to have a much more blended hybrid model for delivery, which means the professionals wrap around primary care, wrap around the primary care home. So you have mental health services which transition from secondary care back into primary care and are locally based. The voluntary sector and community sector are an important linchpin of that, working in conjunction with registered professionals and statutory services. Diagnostic care, social care, this is what we're trying to create with the primary care hubs. And some of them are really well established, like in Peel. Ramsey is doing really, really well, but that is the direction of travel, which means we use those secondary care services when we absolutely need them. And if we can, we will deliver those services in the community, local to people. So, the timeline for this work. We have been fortunate at getting health and care transformation funding. That gives Manx Care a little bit of a headache because that funding is non-recurrent, but we have sufficient, we know these are going to work. So we have taken the risk of recognising that we will fund these recurrently when the transformation period is over. So Hear and Treat has already gone live. Same-day emergency care, the ambulatory model, and intermediate care are mobilising at the moment and will formally launch early next year, as well as See Treat and Leave. And primary care at scale, we have started that work. That work is ongoing now, but we anticipate it will be another couple of years before that model is fully embedded. But all of that work on those 7 pillars of care delivery have started. Okay. So I've given you a very high-level whistle-stop tour. I have a team of people with me who will be able to answer any specific questions on any of the presentation or anything else you would wish to ask us. So can I ask my team to come up on stage? Right. So we'll take the question from the gentleman at the back with his hand up. Good morning.
That's it. Yes, hi, my name is John Shepherd. I'm a family carer and have been advocating for improvements in the way that family care is managed and resourced in the Isle of Man for over 20 years. I did actually engage with Manx Care shortly after you were established, and at the time there was discussion of there being some sort of meeting to discuss the options of this. Unfortunately, the pandemic got in the way. I believe, I mean, obviously at the moment there is a terrific shortage of carers in both the third sector and within the government provided service. Family carers save the Isle of Man government millions of pounds each year and are paid, I mean, in our case we do over 100 hours a week, which equates to about £1.30 an hour effectively. We do it because we care about our family member, not because of the money. But there is an enormous amount of expertise amongst family carers in the Isle of Man, which is by and large ignored. If the model of funding for family care was changed to, rather than being a benefit, it became an actual salary in some form. And as a part of that, family carers were examined and given a level of qualification, or their skills were assessed and a qualification along the current models was ascribed to them. This would give the whole service an enormous pool of people that you could call upon, and would also encourage any family members of families where there is a person with a severe learning disability, for instance, to actually engage in it as a career option rather than as something they do because they just care about their family member. I mean, the other side of this is, I mean, we currently use Crossroads as our main provider, and there is a significant problem. Clearly, the funding that is provided to Crossroads and presumed to other third-party providers allows them to only pay wages significantly less than those available to government. As a result, they are effectively the training arm. They've become the training arm for the government services. They train staff up. Once they get to a certain level of qualification, they work into government, which means that Crossroads are consistently and continually understaffed. Now, okay, I know there's financial problems at the moment, but I mean, this is clearly inequitable and, something that should be looked at in that basically groups like Crossroads should be able to provide and pay similar wage levels to either private companies or to the government. And I mean, at the moment, they simply can't.
Okay, thank you. So I'll probably ask David to pick up on the wider piece of work around carers strategy. I absolutely acknowledge that what we've got is pay differentials across similar professions on the island. I genuinely don't know how we resolve that, because at the moment we're all bound by different terms and conditions. I think, if I was being honest, I think it needs a wider conversation across government. It's not something Manx Care in its own right can solve. I know we run various sectors of Manx Care which lose money because the income we get for those service lines is less than what it costs to run them. And the care home sector is the one which is very pertinent. We actually lose a lot of money running that sector. But yes, I would totally agree that some sort of pay strategy and equality across health and care provision, whether that's government-led or outside of government, would be the panacea. But I'm not sure I can solve that as Manx Care, but I do take your point entirely, and I'll ask David to talk about the carer strategy.
Thanks, Teresa, and thank you for your question, and thank you for really describing some of the key issues at the moment, and have been issues for some time, haven't they, on the island, in terms of carers and how we support carers and enable carers to continue to care for as long as they want and are able to do so. And that's a big challenge for the island, and in fact for any organisation who is supporting carers. We are absolutely dependent upon the services and the support that carers provide. Without carers, we would be absolutely overwhelmed. and we wouldn't be able to cope as a health and care system. So I think it's right to acknowledge that. So what are we doing about that? I think there's been some recent work done across the island. There's been some surveys completed, and we've asked carers what it is that they would want and need for the future to enable them to continue to care for as long as they want to and they're able to. So DHSC commissioned that piece of work. There's a strategy now being developed on the back of that, which will come forward with some very clear recommendations about what we can do differently and better to improve the support for carers. And you're right, it isn't just about carers, it's a wider issue, isn't it, across the whole community in terms of how we make sure that that level of care and support is available for people when they need it, and ideally at home or in their local communities. So there is still quite a bit of work to do. I think we are a little bit behind in terms of other local authorities, in particular in the UK. But even then, I've worked for a lot of authorities in the UK, and I've always thought that we've never done enough to be able to support carers. So it's always work in progress for me. So we'll continue to do that. It is across government that we need to support this, and the whole system as well. It isn't just about Manx care. So we'll continue to do that. We look forward to the strategy coming out and that being presented and launched, and again, start engaging again with people in terms of how we deliver some of those key recommendations that will support carers in the future. Thank you.
Thank you. Morning.
Hello. On the back of what's just been said, my name is Sue. I am a full-time carer for my husband who has advanced dementia. It's very difficult to do. I have a wonderful GP who is very understanding. Earlier on, what I'm going to say is a kind of an interesting mix here, because earlier on this year, both myself and my husband got COVID for the very first time, and we only got tested on a Friday, and we were both very sick. And I spoke to my GP and we tried to get help, and she said, I can't raise anyone to help you. I'm going to have to do a social admission. So the ambulance came round, and I didn't want my husband to go into hospital, but we decided there was no other choice at the time. But the paramedics came, they assessed Michael, and they said to me, why do you want him to go into hospital? And I said, I absolutely don't. But he's bedridden, he's a dead weight, I can't manage him on my own.
Yeah.
So they got in touch with the community social worker, and the first words out of her mouth to me, are you on income support? No. Oh. Well, in other words, oh, well. And I said, well, you do have a package, but it's only for those people who are on income support. Well, I'm in crisis here. I am sick. I'm looking after my husband who is sick. I said, what about me? And, we'll phone round at the weekend. Can't do anything tonight because it's Friday evening. So phoned round, but it was only the Crossroads, because I have a Crossroads carer, 3 hours a week, which is the norm, came to me and volunteered, because she'd already come round to see if there's anything she could do, volunteered to come in at the weekend under their ASK scheme, not under their care at home scheme. So 3 times a day on Saturday and Sunday, she came in to help me change my husband. Now, if that hadn't have been available, he'd have been in hospital, where I did not want him to be.
Absolutely.
Because it's a very distressing experience going into A&E with, I wouldn't have been able to go in with him. And for a dementia patient, it would be appalling.
Yeah.
So the thing is, it's not only about, well, it is about money, it's about availability.
It absolutely is.
Because I did get some help from ARC, obviously had to pay for it, but I didn't mind at that thing. What I needed was help, physical, practical help for Michael, who in every other respect was okay. And the chief paramedic, I was so impressed with them. They were They were wonderful, by the way. Said, you know, he needs to be here. I thought they would automatically take him to hospital, but they didn't. He needs to be here because all his other signs, all his other stats are fine.
Yeah.
So we don't want to make him worse by taking him into a hospital environment. So although you're sort of partway there, see what I mean? It's the last bit that needs developing.
Totally. And that level of complexity is what we are trying to understand. Absolutely, your husband coming into hospital was probably the last thing that was going to be helpful to him. It would have made his dementia worse, and it's the wrong place for him to be. Intermediate care will be one of those services which will give an alternative to coming into hospital. This system, and it is a reflection of sort of how things have worked, but we have a high number of social-based admissions to hospital. And that does come back to, and the Minister is speaking about this next, that inequity in terms of who pays for care and who doesn't, and what then services are available. And that is exactly what we are trying to address. I always recognise, and it is a grappling issue around 7-day services. You know, the budget does not stretch to provide exactly the same service on a Friday evening, a Saturday and Sunday as what it does on a Monday, Tuesday and Wednesday. And we are trying to make sure there's equity of provision and equity of care over 7 days. But again, that comes back to budget and funding.
Just to finish, of all the phoning round that the social workers did over the weekend, only one care provider came back.
Yeah, and our care providers who work in our system need more certainty, and we've got to commission in a different way. So the bespoke ad hoc, can you just do this at 24 hours notice, is not good for them and it's not good for us. And we have no certainty about the capacity available in the system. What we have to have, and we're working towards, is a commissioned framework. So we know we've got a number of providers there and with capacity that has been commissioned that we can then use at short notice, because it's a very inefficient way. That social worker phoning around all of those care providers is a very inefficient way. And what we needed was something that we could say, actually, this provider's available, they can provide this, they're available tomorrow, we can put that in place now.
That would have made everything.
It would.
So much easier.
It would, yeah. And, you know, that was everybody trying to do the right thing. So you've got the paramedic who has absolutely advocated that the right thing, but the system hasn't allowed. And this is where we need to get to. Our practitioners are wanting and trying to do the right thing. Our systems have to work better to enable that to happen. But intermediate care is such a fundamental building block of making sure those services are more joined up.
Thank you.
Hello, Alison Gom. I just wanted to thank you, actually, for putting that presentation together and explaining so clearly where we're going to go, why we need to go on the journey, and how we're going to get there. There's a lot of change there, and that's difficult sometimes for a lot of people. You've spoken to only a handful of people of the Isle of Man today, and we might all have got it. We might be able to tell our friends, but I just would urge everybody to really think very hard about the way we communicate this to everybody before it happens, because that's the only way that we will succeed, because there's still a lot of view that, you know, we must only see our doctor.
Yes.
We can't see anybody else in the practice. And we know that, you know, there's lots of other people that can care for us and solve the issues. Not everyone has got the message at all.
No.
I think just a doubling, trebling up of effort, if I might make that suggestion. But thank you very much. It's so clear. Everybody can get that. If we could publish or something, the presentation, and make it really widely available, it would be great.
Yeah, no, thank you. We do recognise that this is a significant change. All of these strands are equally individually important, but they all connect together, and that connectivity has to be understood. You know, what we don't want is the public to worry that they're not going to get a responsive service. This will be a responsive service, but it will look different. So you won't dial 999 and automatically get an ambulance. There will be a different clinical assessment. You may not always be conveyed to hospital. That's not a bad thing. That's a clinically appropriate pathway.
Hi, Jackie Bettridge. Actually, I am the Chief Executive of Crossroads Care, and I had no idea we were going to be talked about this morning. I've just come from a mental health meeting and managed to get here on time. I think there has been a lot of change within Manx Care for the positive. I think that we actually have a partnership with Manx Care. We aren't dictated to. I think there needs to be more of it. I still worry for carers. The piece of work that was alluded to around the survey and everything, it was actually a Crossroads piece of work that the Department of Health came on the journey with us. It's a very important piece of work. It's called The State of Caring. It's actually on our website, and it is worthy of a look. And it's not about criticism. It's about how do we move forward to where we need to go. I still think 20 years down the line, carers are the most misunderstood, probably the most important part of caring, to actually go into somebody's house and to send somebody to actually live with somebody who has a care need. It doesn't matter whether it is a learning disability, it doesn't matter if it's a physical disability, it doesn't matter if it's a diagnosis. It is a tough call. And without all of those fantastic people who do that, and we've got over 500 people on our books, last year we delivered over 180,000 hours of care, we will not be able to get to where we're going to get to. You can have all the medics in the world, but if you do not have family members that will care for their own, then we are actually stuffed. And I think, yes, we probably do train our staff and hand them over, which is very sad, but we just are doing our best. And actually, it's not about the pay, it's about the pensions. Yeah? We cannot afford a government pension. We can afford to pay the pay, but we cannot afford to pay the pension. And I think that has to be understood by government, not necessarily by Manx Care, but by government. It's a really important take-home. Yeah?
Yeah.
But well done, guys. I think you're doing a really good job, and we just need to keep moving forward.
Thank you.
Hello, it's Jane Glover. Hi.
Jane.
I totally agree with this move forward, the approach to being more community-based. I have had family members and friends that have definitely stayed healthier physically and emotionally and mentally, if you want to say, by being in their own home, being in their own community and supported. So I totally support that way ahead. My question for you is, how confident are you that you'll be able to get all the ducks in the row, all the right kind of funding, and meet the target of the Island Plan to increase the population by 15,000?
So I think the evidence base around Home First is compelling, internationally recognised, and I think as an island, we just should accept it and move on and not try and challenge the thinking behind that. There's a sufficient evidence base which we just need to accept and recognise that other systems did this 20 years ago. I think the piece of work that the DHSC Minister is leading is of such critical importance to that overall equity of provision, so we can actually distribute that model and have it funded appropriately. I don't underestimate the challenge of that and the messaging, but fundamentally we cannot have a system whereby we have a perverse incentive that actually you're funded to go into a residential home, but you're not funded to have a care package in your own home. that's a fundamental inequity in our system which must be righted. Now, I think the wellbeing hubs, the intermediate care, and that direction of travel we're taking hopefully means that when that inequity that we're talking about with home care provision is resolved at government level and outside of Manx care, we're ready and prepared and we can meet in the middle. So we are proceeding on the assumption that that piece of work will generate the necessary change for this system, because then we'll be ready to meet the requirements that will, and the change that will need to happen on the back of that. So, but in a financially challenged system, it's difficult. But we need to give some certainty to those providers in the home care market who are just waiting for us to give some certainty on this direction of travel. They are so valuable and we can't afford for them to disappear whilst we're putting the plans in place. So I am confident, because I think the evidence is so compelling, it will stand up for itself. Yeah, and David wants to come in.
Thank you. In terms of Home First, I think that's absolutely the right direction of travel for the island. As Teresa said, it's something that's been adopted elsewhere for a number of years now. And I think one of the fundamental building blocks for that is around prevention and early intervention. So what are we doing to support people in local communities to be able to divert, delay and reduce the need for ongoing statutory care, whether it's health or social care? How are we connecting people to those community services that are out there and doing fantastic jobs? There may be some gaps in some areas that we need to have a look at. But I think that's one of the fundamental areas we need to work on in terms of that prevention, early intervention. If we don't do that, then the demand, because of the demographics, will absolutely overwhelm us in the very near future, if not now. So I think people understanding that and supporting people in local communities, and we all have a responsibility for that, is key, I think, going forward, as well as all of the other services that we're talking around today, around intermediate care, home care, day services, carers, etc. So all those elements need to come together to be able to provide that support for people to help them remain in their local homes wherever possible and for as long as possible. So absolutely the right thing to do. How we get there is the challenge for us all, I think.
Hello, my name is Barbara, and I come from other medical systems, so I hear and I agree with just about what everybody has said. But the problem is, I don't think you're ever going to plug the leak. All you're going to be able to do is slow down the amount of the flow. Hospitals were never created as a money-making or money-saving thing. They were created as a charity. And we took care of our poor, we took care of our sick. So now what we need to do is try and figure out, how are we going to do this? Emergency rooms were created to save lives and save limbs, not to take care of people when they couldn't get hold of their GPs. And I think this is part of the problem of people. They cannot get hold of people. And I've worked in emergency rooms, I've run clinics, and as this lady was saying, 5 o'clock Friday afternoon is when you get those SOS calls. And then you're calling the support staff, how am I going to take care of these people over these 3-day holidays, or bank holidays as you call them? And I don't know if this is the solution, and I don't believe in complaining about something unless you do have a solution on the back end. But you can't have people offloaded into an A&E because they can't get hold of a GP. We developed urgent care settings. We developed Saturday clinics. We developed these types of things. Yeah. And I'm not sure if going to the house, we also developed where we paid minimum wage to family members who couldn't go out and work because they were taking care of the patients. And you're trying to plug the leak for the Treasury on paying out money, but this may be cheaper in the long run. And believe you me, what you're paying a day for emergency room visits and for hospital days is nothing compared to where I have been. We're talking $10,000 a day. So I applaud what you're doing, but I think what you're going to have to do is slow down what you're paying, not eliminate what you're paying.
Yeah, no, I would agree. And, you know, I've worked in the NHS for 30 years, and you always feel as though you've got the finger in the dike waiting for the tsunami if you take your finger out. We're just trying to do the best we can with what we've got. And we've recognised that no amount of funding would ever get us what we really need. the shift we're trying to create, and, you know, I started by talking about the importance of public health. Actually, we've got to try and make that left shift, because we want the best possible emergency care. I would suggest, in order of priority, we want the best possible cancer care. We want to be able to treat people who need operations. But that also means, with the limited funding we have, there are difficult choices to be made. And I don't want to get into what should people pay for, but inevitably choices will have to be made about what can be funded and what are the priorities, and what can't be funded, and we're going to have to do something different. You know, we have to have those debates all the time. I would love to reduce waiting lists further. We just can't spend any more money. We're already overspent. But being able to do some of this work, which we know is evidence-based and demonstrates value for money, at least starts to move us in that direction. But I think that whole 7-day service philosophy, it's what we've all been grappling with in NHS services, not just from a financial point of view, but outcomes for patients. If you're admitted to hospital over a weekend, your outcomes are generally worse than if you are admitted on a Monday or a Tuesday or a Wednesday. And that's the sort of level of inequity we have to acknowledge and try and erode. We've got the very big bits of inequity, which is sort of the care home piece, but equally we have inequity in care and provision that we shouldn't tolerate. There is no simple answers, and I'm probably being vague, but I don't disagree with anything you've said. We are trying to iron out some of those irregularities in what is a very small system, but also an incredibly financially challenged system, where in some specialties and some areas of service delivery, we are trying to catch up at least 20 years with our contemporaries. Gentleman at the front. Sorry? Oh, so this is the last question.
I'll speak very quickly. In your description of the care providers, it seems to me there's a person missing. And increasingly, I, as a patient, feel as if I'm taking charge of what's happening to me. You go and see, I don't want to describe my particular symptoms too much, but an ology at Nobles, and they say, fine, and now we'll remit you back for GP monitoring and care. Doesn't happen, is the truth of it. What are my cholesterol levels? Well, I know what they are because I've arranged to go and get a blood test. What are my PSA levels? Well, no GP has ever said, it's time you had those checked again. No. I do the checking. And I really do think that a lot of the time, it surprised me. The GP said to me, surprisingly, I saw a GP, the GP said to me, when did you last take your blood pressure? This is a change. It may be entirely appropriate, but I think some of us would welcome some guidance on this. At what point, after 12 months, 18 months, 2 years, should I say, it's time I had another test for that? And I don't want to be someone who's anxious about my health, but equally, I don't want to be ignorant of something that's going wrong that I'm not aware of, and nobody else is proactively following that.
Yeah, no, I would agree. I think there's 2 elements to that, isn't there? There's the whole philosophy, which I would very much support, about people taking personal responsibility for the health and no decision about me without me, that type of approach, which is relevant in all areas of our provision, but particularly relevant in mental health services and social care. But then there's also, what can we offer to keep people well? And, I think, well, I know we have many deficits in that wider well-being model. That's what we're trying to address. Basic things like the Manx care record and the ability for professionals to share information will help some of that. because at the moment we are all in silos with different bits of the system not talking to each other. So it makes it even harder for professionals to share information and to see various results. But I would particularly in a system like this, and I think there's always merit in, if you can, taking responsibility for your own health and guiding professionals in that way should you feel able to. I think it's entirely reasonable that we almost set that expectation. We don't want to be paternalistic. We're not going to dictate treatments. We are going to make sure we have got a consistent and equitable offer, and that will ultimately mean difficult choices. And we're going to have to do that together. And the public are going to have be on board with some of those conversations we're going to have as we make some of the best health and care choices for the island in conjunction with the people on the island. I think that's the final question. Thank you all for coming to our session. Thank you to my colleagues on the panel who probably feel like they've been let off lightly, particularly the three at the end. But thank you all for taking the time to come this morning.